Hello guys, I'm Dr. Ranjan, your pharmacology faculty, and I welcome all of you to today's discussion of the recently conducted INI-CET exam. And today I'll be discussing the pharmacology questions, and all of you know, you have been through the exam, and the least that can be said about this exam was it's a weird exam with a lot of MCQs asked from another planet like Mars. But nevertheless, you see, these are competitive exams and they're not there to take you in. They're there to send you out. Now, whoever remains, they take in. And that is the reason why they keep on asking such type of questions from time to time. And specifically, these questions are asked mostly in an exam like INI-CET. And from time to time, you have some weird exams. But remember, never lose heart looking at these weird exams, because if you look at the last 10 years, I have been looking at the INI-CET, plus before last 2 to 3 years, the AIMS, the JIPMA, time to time, they ask these weird questions which make us feel depressed. And that's normal, right? Don't worry about that. So guys, today there are lots of new MCQs which have been asked, and I'll try to discuss those in detail so that if you're preparing for the next November INI-CET exam, if that happens at all, then don't forget to add the new points to your notes. I'll be talking about non-small cell lung cancer, vancomycin nomograms, etc., etc. So please add this to your notes and write specifically INI-CET so that you can cover them before the exam. So let's begin, guys. So let's begin with the first question, guys. You can see it's a question on a new drug, and it might have, blown you off track. Which of the following is a new drug approved for treatment of Rett syndrome? Right. The answer to this question, see, even if you didn't know the answer, you could have ruled out the answer from whatever drugs we have discussed. Now, see, the answer here is trofinetide, and this is a drug which was approved in March 2023. So I must say, your examiners, they want to test everything about this world. Even these new drugs approved just a couple of months back. Now, see, all right, you know that in our exams, competitive exams, even if I don't know the answer, I can always rule out. So, because it was such a recent drug, we did not discuss in our lectures, but we did discuss about these drugs. Olkigipand. It is a blocker of CGRP receptor. Arenomab is also a blocker of CGRP receptor, whereas lasmiditan, it is 5-HT1F agonist. And all of these drugs I've discussed, guys, and they have one common use: migraine. So the beauty is they've combined all the new drugs in migraine, right? And with one drug, that is trofinetide, for treatment of Rett syndrome. Now, see, this is a new drug, and for Rett syndrome, we did not have any drug. And why did they ask? See, I've told you this time and again, which new drugs are important for exams, those new drugs which can drastically change the outcome of a disease. So I don't have any drugs for Rett syndrome. Finally, I have one drug, and that's important. Now, briefly, let us discuss what is this drug trofinetide about, right? So trofinetide, it has been synthesized from IGF-1 or insulin-like growth factor 1. As I said, this is how it looks like. IGF-1 is nothing but it is a polypeptide. And in this polypeptide molecule, what they have done, they have isolated the last 3 peptides. And this is glycine, proline, and glutamate, called as GPE. So this peptide or tripeptide, glycine, proline, glutamate, this is called as GPE. You can see GPE analog. So trofinetide is a GPE analog derived from one part of IGF-1. And what it does, like insulin-like growth factor, it promotes growth or promotes maturation of synapse, or it promotes synaptic maturation. And synaptic maturation is a problem in Rett syndrome. So guys, I'm again, try to pay your attention here. It's a proposed mechanism. We don't know. Its mechanism of action is unknown, right? Unknown. We don't know how it acts. I'm telling you the proposed mechanism. It must be acting by some mechanism, isn't it? And that is by promoting synaptic maturation because of the growth factor IGF-1, this 3 peptide, right? Glycine, proline, and glutamate. So this is the mechanism of action. So Trophine if it is repeated, if it is asked, these are the points which I have discussed. So once it has been asked, it will be asked in the coming exams. And the route of administration is remember, is given by oral route, right? It is given by oral route, or it can also be given by gastrotomy tube. Also, you can give it directly into the stomach. So oral route or gastrotomy tube if the patient is not able to take orally, right? Next question, guys. A patient was started on a drug for mood disorder and he developed priapism. Priapism, right? That is painful erection. What is the causative drug? Now look at these options, guys. What is the causative drug? Let me know the answer in the comment box. Come on, comment. This is an easy one. That is the reason why I'm asking you the answer, right? So what is the answer here, guys? The answer is trazodone. And this is an MCQ that falls in easy category. So these are rank deciding MCQs, right? Now see, obviously, this MCQ, the older one should be able to solve by ruling out all the three options. But it is a difficult one, but you have to solve this to get a good rank. But to get into the race, you have to solve such type of questions. Trazodone. Now, a little bit about why trazodone. Now, if you remember, I've told you the basic concept of erectile dysfunction. The basic concept of erectile dysfunction is any drug that increases serotonin would stimulate 5-HT2 receptors, and that is responsible for erectile dysfunction. So what do I need for erectile dysfunction is excess of serotonin acting upon 5-HT2 receptor. And who increases serotonin? All the typical antidepressants, isn't it? All of them. All the typical antidepressants, be it MAO inhibitor, tricyclic antidepressant, SNRI, SSRI. There's something I have discussed. Then, what did I teach you guys? Remember, no erectile dysfunction is obviously seen with atypical antidepressants which do not act by increasing serotonin. Like bupropion, it acts by increasing dopamine, norepinephrine, but it has nothing to do with serotonin, so it does not cause erectile dysfunction. Or a 5-HT2 blocker, it is not acting by increasing serotonin, but there is a catch here. Now see, this will not cause erectile dysfunction, but priapism as a side effect is seen with trazodone. But why not with mirtazapine? Because remember, see the basics, right? What did I discuss? Mirtazapine is a 5-HT2 blocker, plus it also blocks alpha-2 receptor, because of which it increases serotonin as well as norepinephrine. So at one end, you can see here, but if I go back, I told you that erectile dysfunction is because of excess of serotonin. If I reverse this, if I block 5-HT2, that would cause erection. Try to understand this. 5-HT2 stimulation causes erectile dysfunction. 5-HT2 block will cause erection. Significant 5-HT2 block will cause significant erection, and that is called as what? Priapism. Now, if I look at these drugs, trazodone, it only blocks 5-HT2. That is the reason why it causes priapism. But why then priapism is not seen with mirtazapine? Because it's not only blocking 5-HT2, it is also stimulating 5-HT2. So it blocks 5-HT2 directly, plus it increases serotonin, and that is why it stimulates 5-HT2, and the effect is zero. And that is the reason why it does not cause erectile dysfunction, no erectile dysfunction. So bupropion, mirtazapine, there would be no erectile dysfunction, potency would be normal. Trazodone, on the other hand, forget about erectile dysfunction, it would rather improve the potency, cause priapism, and that is the reason why a secondary use of trazodone, it is used in erectile dysfunction, guys. Remember, so this is what we have discussed. This is the basic concept of erectile dysfunction with respect to antidepressants if they are used. So this has been asked earlier, and they have just changed the MCQ a little bit, right? Earlier PYQ was which antidepressant does not cause erectile dysfunction. It has been asked. Once your answer was mirtazapine, another time your answer was bupropion. Now they have asked which one can cause priapism. It is trazodone. That is why it is used in erectile dysfunction. Now let's move on to the next question. True about therapeutic index of a drug. Now this MCQ has been asked a lot of times, but this time this has been asked with slight twist, and many students, they fell right into the honey trap made by the professor, right? So look at the options. Option A denotes safety and efficacy in population. Option B denotes safety and efficacy in individual. Option C is ratio of median, it's not medial, sorry, is median lethal dose in 50% of population to median effective dose in 50% of population. D denotes safety and efficacy after experiments in humans. Now what is the answer? See, many students here directly by looking at this MCQ superficially, they jumped onto option C and they marked option C as the answer. Now, is option C the right answer? Let me know in the comment box, guys. Is option C the answer? Please let me know in the comment box. Now, let us see. Guys, all of you remember, I have taught you this in detail about a DRC called as quantal DRC. And quantal DRC, it's drawn not in an individual. The graded DRC is in one individual, but the quantal DRC is in population. Plus, the response here is binary, yes or no. Like a patient develops sedation, he will say yes or no. He will not say that I've developed 10% sedation. Or if I'm using a drug for ovulation and pregnancy, the female would say yes or no, means I'm pregnant or I'm not pregnant. She cannot say I'm little bit pregnant. That is not possible, right? So the response is, you can see the response is in percentage of population and logarithm of dose I take here. This is response in 100%, 50%, 0%. Now, what happens if I take 50% and draw perpendiculars to three things: effect, toxicity, and lethality, and I draw perpendicular to the dose axis? What do I get here? What do I get here? I get ED50, I get TD50, I get LD50. So these are the median doses. ED50, it is a dose required to produce effect in 50% of population. TD50, it is a dose required to produce toxicity in 50% of population. LD50, it is a dose required to lethality or to kill. Now think here, pause for a moment. Can I kill population? Can I kill 50% of population? No, I can't. The only person who can kill 50% of population is Thanos, right? And we are not Thanos, we cannot do that, right? You cannot do that. Otherwise, we'll be solving 50% of population, the problems of this world. So lethality or LD50, I can kill animals, guys. So LD50, remember, is something that is determined only in animals, whereas ED50, TD50 can be determined both in humans as well as animals. And you understand this basic concept. So therapeutic index in humans is TD50 by ED50. Animals, it is LD50 by ED50. So these are the formula for therapeutic index. Now I have discussed this everything as it is in the class. Now let us go back to the question. Now look at the question. Now, if you thought C is the answer, will you again go for answer C? Now look at the option carefully. It's a ratio of median lethal dose in 50% of population to mean effective dose in 50% of population. Median lethal dose in 50% of population. Can I kill 50% of population? No, right? So here it should be animal, right? C is not the right answer. Now what am I left with? It has nothing to do with experiments, right? Now here therapeutic index denotes safety and efficacy. So my answer can be either A or B. Now, it is not about individual, it is about population. So it is about safety and efficacy in the population. So therapeutic index, it is not much about efficacy, rather it is much about safety. So better answer is safety. Efficacy is not much we determine in case of therapeutic index. But anyways, if these are the options, the best possible answer here is option A, guys. So you can see option C was the honey trap. So the moment you look at this option, you fall in love with this option and you cannot think about any other option, right? But you understand, that's a wrong answer. All right, guys, let's move on to the next question. Nomogram used for vancomycin dosing is, these year's questions were right out of this world. They might have got this question from Mars. Now, I'm frankly speaking, I mean, these type of questions, they are distractors, right? They don't determine your capability as a student. So never feel bad if you're not able to solve who was the scientist, where was he living, what is his address, on which floor he was living. So these are all useless questions. But anyways, they've asked, we need to see, we need to understand the nomogram once and for all, so that if this topic is repeated again, you should be able to solve any question related to the nomogram. Now see, here, what is the answer, guys? Here the answer is MASK. MASK nomogram is used for vancomycin dosing. So let me briefly tell you about vancomycin dosing and why do I use this nomogram. See, the problem is vancomycin, it's a nephrotoxic drug, right? It's a nephrotoxic drug. So I need to keep in mind that I need to maintain efficacy of vancomycin. So whenever I'm using it against, let us say, Staphylococcus, MRSA, I need the drug to be effective effective, plus it must be without toxicity. Without toxicity, right? So it's a nephrotoxic drug. So what is my aim of using a nomogram? First of all, try to understand. I need to maintain such level of plasma concentration, that is CSS, steady state plasma concentration. It should be adequate for efficacy. It should be adequate for efficacy, but it should not be more than the desired CSS level so that I don't have toxicity. And for that, historically, there are different types of nomogram. But in the current world, what we use is a software. So I'll tell you about all of this, the past and the present, about this nomogram. So see, the nomograms used for vancomycin dosing, there is one called as INI-CET and Mollering one, which is based upon serum creatinine clearance. Sawchuk and Zaske is based upon first order elimination of vancomycin. So basically, it is based upon pharmacokinetics. And how it is based upon pharmacokinetics, I'll tell you in a short while. Now see, here, the INI-CET and Mollering, they use creatinine clearance. So you can see here, the graph here, I've drawn here on the x-axis. On the x-axis, you can see it is the creatinine clearance. And here, the vancomycin doses are there, right? So the vancomycin doses can be, 500 milligrams, 1 gram, 1.5 gram, 2 grams, and so on. And here, our creatinine clearance value is there. And I have a line in the center. Now, what I need to do is for each creatinine clearance value, I can draw a perpendicular, and that perpendicular will meet some value here. So for example, if this is my creatinine clearance, so this is my vancomycin dose. So you see, based upon creatinine clearance, I'm trying to calculate the dose. And this is why I do this. Look at this, my aim. What is my aim? My aim is to maintain a CSS, is the steady state plasma concentration of around 20 milligrams per liter if the patient has severe infection like endocarditis. But if it is a mild infection like cellulitis, mild to moderate infection, then it is 50 milligrams per liter. Now, why do I maintain these steady state concentration? Because I'll get an area under the curve more than 400 or more than 360. Now, to achieve that area under the curve, what I take is what would be the steady state plasma concentration. So this is my aim. This is my aim to achieve. And to achieve this, what I do, based upon my creatinine clearance, I decide a particular vancomycin dose. But remember, it is not the best method. It is not the best method. We have a better method as compared to INI-CET and Mollering, and that is called as the Sawchuk and Zaske method, which is based upon pharmacokinetic parameters. Now, let us say I've given 2 doses of vancomycin, and you can see the plasma concentration here increases, then decreases, then increases, then decreases. Now, whenever I give the first dose, this was my first dose. After first dose, I will find out the CTR. CTR is the trough concentration. Trough means the lowest concentration before the second dose. So this is my second dose. So before second dose, the lowest concentration CTR is determined. Second, after the first dose, in second dose, I'll determine the Cmax and CTR. So based upon this concentration, I calculate. There are different formulas. I'm not going into formulas. They are hugely complicated formulas. I'm just telling you what is the mechanism of using these nomograms. I calculate elimination constant. So here, this slope is K elimination constant, and I'll calculate volume of distribution. So I calculate elimination constant and volume of distribution in that patient, and based upon that, I'll extrapolate the future CTR and Cmax, future trough concentration and Cmax, and based upon that, whatever is my desirable CTR and Cmax, based upon that, I can change my dosing. And this is called as Sawchuk and Zaske method, and it is based upon the pharmacokinetic parameters, and it includes a lot of mathematics. Whereas this one, it is primary. It looks much easier, but it is not as good as Sawchuk and Zaske method. But this one is based upon creatinine clearance. It is much easier to use, but the better one is this one. But remember, even both of these are not the best one. The best one is yet to come, and that is a pharmacokinetic model. Now see, remember, until now, I've talked about the pharmacokinetic model. I've talked about the creatinine clearance model, right? The Maske one and the Savchuk one. So in the pharmacodynamic model, what I do here is, see, I draw the AUC, and you can see the area under the curve I draw here based upon CTR. So it is AUC was calculated based upon CTR. So this is not the exact AUC. I'm extrapolating. I'm making a guess that if this is the CTR, this could be the area under the curve. And then I calculate something called as MIC. And I calculate the AUC by MIC. So this is the ratio of AUC by MIC ratio. So the AUC by MIC ratio must be more than 400 for good efficacy. For good efficacy. And if it is more than 400, then the CSS is 150, 15 by 20 milligrams per liter. Now see, try to understand this. If you remember, before this, what did I say? Before this, I said that I try to maintain the steady state concentration you can see here was how much? 15 to 20, right? And by this pharmacodynamic model, I'm trying to maintain the steady state plasma concentration by 15 to 20 milligrams per liter. And that is demonstrated by if the AUC by MIC concentration is more than 400, right? So that tells us that the MIC or the CSS steady state concentration is 15 to 20 milligrams per liter. So based upon this, now I can say that the effect is adequate. And this is the pharmacodynamic model. Now, for a while, we thought it is also good, but again, it also has problem. What is the problem with the pharmacodynamic model? The CSS I'm aiming is around 15 to 20 milligrams per liter, right? This is what I'm aiming. But AUC in many patients, it goes beyond 600 and that causes nephrotoxicity. So the problem is, see, what did we say? Our aim. So let me tell you again, you might not have got this because pharmacodynamic model is a little bit confusing. In pharmacodynamic model, my aim is to get the AUC by MIC concentration, the graph, the ratio, it is a better predictor of good efficacy. My aim is to maintain is more than 400, right? Maintain it more than 400. Now what is that tells us if it is more than 400, if AUC by MIC ratio is more than 400, that the steady state plasma concentration is usually 15 to 20 milligrams per liter, right? So my aim is to give a dose in such a way that the AUC MIC ratio is more than 400, right? So fair enough, we'll see effect. But the problem is in many patients, the steady state plasma concentration was maintained at 15 to 20 milligrams per liter, thinking that at this level, the AUC by MIC ratio would be more than 400. But the problem was the AUC in many patients, it exceeded more than 600. So this steady state plasma concentration is not exactly representative of the AUC in most patients. So what is the solution to this? The solution was we use a software called as Bayesian software and programs. It is to predict the AUC. Right. So what is Bayesian software? Let us try to understand. See, it is based upon Bayes theorem. And Bayes theorem, it is a statistical theorem, statistics. It determines the probability of an event occurring based upon historical data. Right. So what previous patients have gone through. So if I have a data of pharmacokinetics of previously treated patients, their AUC and MIC, and I can compare that to my patient now, and I can extrapolate what is the dose I should be using in my patient. So how we do this? See, in Bayes theorem, we first collect a pharmacokinetic data for past patients with vancomycin. So suppose I'm living in the area, North India, Delhi. So I'll have a database. I'll create a database. So it is a software, try to understand, where there is a database of pharmacokinetics of vancomycin in a population, right? Then I collect the pharmacokinetic data of current patient on vancomycin. So I have a database of pharmacokinetics of vancomycin for entire Delhi. Suppose I am the patient and I am, suppose when I go to the hospital and they give me vancomycin, then they collect various data, the trough concentration and the CSS, and then they extrapolate different pharmacokinetic parameters like volume of distribution, etc. Then what I do is I compare my pharmacokinetics with the population pharmacokinetics, and based upon that, I try to extrapolate what should be what should be the basic dosing, so that basic dosing, future dosing, because I've been given the first dose. So I'll calculate my second, third dose. I'll calculate based upon, by comparing it to the population pharmacokinetics, so that the AUC to MIC ratio is 400 to 600. So usually nephrotoxicity is seen when it goes beyond 600. So my aim here, it is to maintain between 400 to 600. See guys, even this is not perfect, but if today they ask you which is best, then remember Bayes theorem, or this is called as the Bayes program, or Bayesian software. So this is what I do by a software called as Bayesian software. And what is the problem of the Bayesian software? It is a software and it is costly. So that is the reason why it is not present everywhere. So people, they can use the nomograms. Different hospitals have developed their own nomograms as well. Now see, so this is a very confusing topic, but here remember at least this much. Let me summarize. Masque, and if you did not get everything else, is okay. Try to remember this much, that Masque and Mollering, it is based upon creatinine clearance. Savchuk and Zaske, it is based upon pharmacokinetics, whereas the last one, which I discussed, the Bayes software, right? The Bayesian software or Bayesian method. This is called as Bayesian method. This is based upon pharmacodynamics, and that is population pharmacodynamics, right? So it is based upon how a drug behaves in a population. We compare that with an individual and we try to extrapolate what could be the possible dose. If they ask you today which is best, the Bayesian method or Bayesian software is the best for vancomycin dosing, right? Now let's move on to the next question, guys. Now see, look at this question. Osimertinib is used in non-small cell lung cancer with mutation due to. Now see, again, these mutation questions, these are usually asked by JIPMER. They love such type of MCQs. Like earlier, they have asked a lot of times that T359 mutation in CML, right? And now they have got hold of non-small cell lung cancer. Now guys, here the answer is T790M mutation, right? T790M mutation. So let me briefly tell you, see, the non-small cell lung cancer going forward is an important topic for INI-CET, if it happens. If next happens before that, I can say, but if INI-CET happens again, then non-small cell cancer of lung is an important topic. So let me tell you briefly about the treatment. Now see, non-small cell lung cancer, you have to look at two things, right? Are the mutations present or absent? If the mutations are present, there are lots of mutations, but two mutations which are common: EGFR tyrosine kinase mutation and ALK, anaplastic lymphoma kinase mutation. Two types of mutations are there. I'll discuss this in a short while. Before that, if the mutations are absent, in that case, the treatment of choice, see, look at the treatment of choice. We combine an immune checkpoint inhibitor with chemotherapy, and the chemotherapy is the cytotoxic drugs like cisplatin or carboplatin plus pemetrexed or paclitaxel. So these are the chemotherapeutic or cytotoxic drugs I combine. And the preferred one, the one I preferred is this one, pembrolizumab. So I can use either pembrolizumab or atezolizumab plus chemotherapy. The preferred one or the treatment of choice is this one. Treatment of choice is pembrolizumab plus chemotherapy. An alternative is atezolizumab plus chemotherapy. There is second option, double immune checkpoint inhibitor therapy, where I combine two drugs, nivolumab plus ipilimumab, right? So this is what I do. And there are some, named trials which were done, which I'll discuss in the next question. Let us see if the mutations are present. See, there are two types of mutation I told you earlier. One is EGFR tyrosine kinase mutation. Second one is ALK mutation. EGFR tyrosine kinase mutation, there are three classes of drugs: first generation, second generation, third generation. The first generation drugs, as you can see, these are the older drugs, gefitinib, erlotinib, and they can be used. But if these drugs are used, their efficacy or it declines after 1 to 2 years due to mutation. That mutation is T790M mutation. That mutation is T790M mutation, which MCQ has been asked. Now, for resistance, once resistance is seen because of this mutation, we developed second generation drugs like afatinib and dacomitinib. The problem with these drugs are they are effective, no doubt. but they're very toxic. So we had to develop a third generation drugs like osimertinib, and this osimertinib, it is also effective in L850, 858R mutation, right? So one is T790M mutation, second one is L858R mutation. More common is this one, which is more common. This one is more common. This one is rare. Now, look at this one point. Second point is, if there is ALK mutation, then I can use first generation drug. Again, first generation, second generation, and third generation drug. First generation drug, I can use crizotinib, but again, after using crizotinib for 1 year, 2 year, I develop resistance, and that resistance because of L1196M mutation. In that case, I can use second generation drugs. So if not crizotinib, I can use ceritinib, alectinib, and brigatinib. But again, these drugs, remember, there is one point which they can ask: how brigatinib is different from other ALK inhibitor, ALK. So these are ALK inhibitors. Brigatinib is the only drug in this class which not only blocks ALK, it also blocks EGFR. It also blocks EGFR with T790M mutation. That means it is a drug with wider spectrum. So it can be used in case of non-small cell lung cancer. Suppose there is a patient with mutation of EGFR, that is T790M, plus mutation of ALK, that is L1196M. In that case, the preferred drug would be brigatinib. Third generation drug, lorlatinib, it is effective for all kinds of mutation. It is effective for all kinds of mutation, whatever is there. There are many other mutations. I have not enumerated them because it is difficult to remember. So guys, this is the treatment of non-small cell lung cancer. And see here, there is L858R mutation. This is also seen, but the better answer here is T790M mutation because it is more common. It is more commonly seen, right? The second mutation is less common. So anyways, guys, these MCQs are really difficult. Now, does this mean that I will go on a rampage, mugging up all the possible mutations in this world? No, you can't do that. That is humanly not possible. But if they've asked some topic, you need to remember some mutations only in and around that topic. So for going forward for the INI-CET exam, I must know all types of mutations associated with non-small cell lung cancer, right? So answer is option A. Now, continuing with this trend of non-small cell lung cancer, I told you there are some name trials. The next MCQ is related to that, which is true about Keynote 189 trial. Keynote 189 trial, and I have discussed something about this. Now look at the options. Nivolumab is used in non-small cell lung cancer. Nivolumab plus chemotherapy is used in non-small cell lung cancer. Pembrolizumab is used in non-small cell lung cancer. Pembrolizumab plus chemotherapy is used in non-small cell lung cancer. So I told you, a short while ago, if you remember, that non-small cell lung cancer, if mutations are absent, I prefer immune checkpoint inhibitor plus chemotherapy. That is my treatment of choice. And the preferable is pembrolizumab plus chemotherapy. Other option is atezolizumab. So here, this trial was exactly about pembrolizumab plus chemotherapy in non-small cell lung cancer. So you can see here, treatment of non-small cell lung cancer. Again, I've repeated the same thing. Immune checkpoint inhibitor plus chemotherapy. Immune checkpoint inhibitor, pembrolizumab is used. So chemotherapy plus pembrolizumab or placebo. There are two trials. One is Keynote 189 trial. One is Keynote 407 trial. The ratio here, see, remember, chemotherapy plus pembrolizumab or placebo. So the ratio of chemotherapy to pembrolizumab or placebo, the number of patients which are divided, it was either 1:1 or 2:1. So the one trial was Keynote 407, where the ratio of patients was 1:1. Here it is 2:1. Keynote 189 trial. That is so that is the only difference in this, in case they ask you. There is another name trial, and that is Checkmate 227 trial. And Checkmate 227 trial is, as I say, it is the double immune checkpoint inhibitor combination, which I told you earlier. Nivolumab plus ipilimumab, Checkmate 227 trial. So these are the names which they can ask. So what you can do is, see, I have already told you this time and again, while teaching pharma, you'll find some points which are difficult to remember until and unless you revise them multiple times. So take this non-small cell lung cancer, write it on a pasted paper and paste it on the wall. Whatever I've discussed now, most of the MCQs will be asked from this part only, right? Now, moving on to the next question, guys. Drug used for trastuzumab resistant HER2 positive breast cancer is. So here the answer is lapatinib, guys, and I have discussed about this. And lapatinib, we have discussed how we treat HER2 positive breast cancer. Now you can see HER2 positive breast cancer. I've taught you this. The drug of choice is trastuzumab, and if the patient does not respond to trastuzumab, then I can add pertuzumab. Now, pertuzumab is also blocker of HER2, but the site of action of trastuzumab and pertuzumab is different. So, pertuzumab can increase efficacy of trastuzumab, right? Though both are HER2 blockers, but at different sites. Lapatinib, I can add lapatinib, which is a blocker of HER2 as well as EGFR, whereas neratinib is a blocker of HER2 as well as HER4, right? 2 and 4 both can be blocked by these drugs. So breast cancer is always an important cancer, guys. You cannot miss MCQs on breast cancer. They will be asked from time to time, right? So what are the other options here? You can see Vesmodegib. So DEG is a hedgehog pathway inhibitor. So hedgehog pathway inhibitor, it has been approved for treatment of basal cell carcinoma, right? Vemurafenib, dabrafenib, these are BRAF inhibitor, and they're approved for malignant melanoma. Erlotinib, I just now discussed, guys. Erlotinib, gefitinib, they're used for treatment of what? Non-small cell lung cancer, right? We have discussed that. Right, so next, moving on to the next question, which is not a difficult one. It is in fact a repeat. Many years back, they had asked, around 8 years back, they had asked in NEET PG, the same question, exactly similar question. A diabetic patient was started on a drug that decreased HbA1c from 7.6 to 6.8. She started complaining of itching around vulvovaginal area. Which drug was she started upon, guys? Let me know the answer in the comment box. I'm asking you to comment at least this answer because it's an easy one. You know it, I know it, and the examiner also knows it. So what is the answer here? Guys, comment, let me know. What is the answer? Guys, the answer is canagliflozin. It's an easy peasy one, guys. And why? So what I've taught you, let me briefly cover it up again. Whenever I use SGLT2 blockers, what happens in the urine? See, sodium linked glucose, S and G. So what increase in the urine? G and S, sodium and glucose. When glucose increases, it is a feed for the bacteria, for the fungus. There will be UTI, vaginal candidiasis. And you know what is the most common presentation of vaginal candidiasis? It is pruritus. Females will present to you with vaginal pruritus. Sodium increases, and you know, sodium always drags water along with it. And that would cause diuresis, that would cause dehydration, that would cause hypotension. And probably because of this diuretic effect, SGLT2 blockers, they decrease CVS mortality as well. So remember, CVS mortality, it is decreased by SGLT2 blockers plus GLP-1 agonist. And GLP-1 agonists probably decrease mortality because they have a decreasing effect on the weight. They can cause weight loss. And you know, GLP-1 agonists like semaglutide, liraglutide are also used for treatment of obesity, isn't it? Now moving on to the next question, guys. And again, let me know the answer. Let me know the answer in the comment box, guys. This is also an easy one, isn't it? This is also an easy one. Which of the following statements is true regarding lithium? Approved for absence seizure. Approved for absence seizure. Absolutely not. It is not absorbed in the stomach. False. It's given by oral route. It can cause fine tremors in therapeutic range. That is correct. It is not teratogenic. Is false. It causes abstinence anomaly. Fine tremors are seen in therapeutic range. If it is toxic range, then the tremors, they become coarse. And this is something I have taught you, right? So option C is an easy one. There is no difficulty here whatsoever. Now moving on to another easy question. Guys, again, this is easy one. Match the following. See, what I've seen in pharma, I've told this time and again, in INI-CET, the MCQs on match the following, at least in pharma, what I've seen, they're easier ones. The only difficulty is you have to match, right? So mirabegron, the straight away, guys, I can match mirabegron to be a beta-3 agonist. Rest, it becomes easy. Indicaterol is a beta-2 agonist. Betaxolol, it is a beta blocker. Isoproterenol, I can go for beta. The reason being, it's a beta-1 and 2, beta-1 and 2 agonist both, beta-1 and beta-2, right? Simple, easy one. What is that, right? So guys, they have given you lots of difficult MCQs this time, but they have given you some easy MCQs as well so that you don't feel bad, right? Look at the next question. Oh my God. A large one, right? A lengthy one. A patient in the emergency has following lab parameters: creatinine 1.5, blood urine nitrogen 45, the chest x-ray, pneumonia with infiltrates in the middle part of the right lung and patchy infiltrates in the left lung is given. In gram staining cultures, only rhinovirus was isolated. The patient is shifted to ICU. What is the best treatment choice in this option? Now, this is at best what I could get from the students, and I'll try to find the answer based upon whatever I have. So, all of you know, it's a case of CAP, community acquired pneumonia. As the patients with CAP, community acquired pneumonia, is the most common virus that is associated with rhinovirus, right? Around 40% cases will find rhinovirus. And the rhinovirus infection is most commonly associated with bacteria like pneumococcus and klebsiella, right? But it is not Pseudomonas or Staphylococcus. Most of the isolates, they are pneumococcus or klebsiella. Now, this information is what is going to help me to solve this MCQ. Should I go for A, B, C, or D? I might have done it wrong, but now that I've told you the basic context of what is being asked here, can you at least now let me know in the comment box what could be the answer? Azithromycin, amoxicillin plus clavulanic acid, piptaz or piperacillin tazobactam per ciprofloxacin, ceftriaxone plus azithromycin. What could be the answer, guys? Anyways, if you don't know the answer, nothing, I'll tell you. So, community acquired pneumonia in ICU. Note the treatment. There are three parts. It can be non-Pseudomonas, non-MRSA, that means Klebsiella pneumococcus. It can be Pseudomonas, it can be MRSA. If we are suspecting non-Pseudomonas, MRSA, and if I'm using an antibiotic, it has to be a beta-lactam like ceftriaxone that can cover Klebsiella, right? That can cover pneumococcus as well. Plus, I have to combine azithromycin so that it can take care of the atypical organisms if present, right? Pseudomonas, I have to give a beta-lactam that is active against Pseudomonas. So I can give piperacillin, I can give carbapenems, I can give ceftazidime, I can give cefepime. So these are all anti-Pseudomonal beta-lactams, can be combined with a fluoroquinolone. This is if it is Pseudomonas. If it is MRSA, all of you know, the drug of choice is vancomycin. If not vancomycin, then I can also use linezolid. Now, based upon this, now if I go back, based upon what the context that I've discussed, at least now can you let me know what is the answer in the comment box, right? At least now can you comment? The answer is what? Ceftriaxone plus azithromycin, right? So, piptaz plus ciprofloxacin would have been the option if it had been Pseudomonas. So, guys, this is what we can get here for treatment. Now, this is another MCQ. See, nowadays the MCQs are multi-layered. You cannot solve an MCQ just from the knowledge of pharma or medicine. You need to know micro as well, right? So it's integration, horizontal and vertical. Now look at this question. A microorganism resistant to meropenem and aminoglycosides but sensitive to piperacillin clavulinate cotrimoxazole. What is the causative organism? Now see guys, it cannot be Acinetobacter, it cannot be Pseudomonas, because Acinetobacter, Pseudomonas, both are sensitive to aminoglycosides and meropenem. So what the students were confused with here were in between option A and D, Burkholderia cepacia and Stenotrophomonas. Now the problem here is, you can see, both the drug of choice is cotrimoxazole. We have studied this, but even from this I cannot solve this MCQ, right? So actually, where the examiner has made this MCQ from Harrison. So in Harrison, there is a table of treatment of Pseudomonas, Burkholderia cepacia and Stenotrophomonas. So what Harrison says about treatment of Burkholderia cepacia, use cotrimoxazole. Stenotrophomonas, use cotrimoxazole. What combine meropenem with cotrimoxazole. Here combine ticagrelin plus clavulanate for Stenotrophomonas. So based upon this, so you can now understand where the MCQs was made from. From here the MCQ was made, and based upon this, I can go for the best answer here. Possible answer here is, that is, my answer here would be Stenotrophomonas, right? Answer would be Stenotrophomonas. So guys, it's a confusing MCQ. It's a difficult one, right? So even if you have done it wrong, you should not fret over it, because when most of you were able to rule out Acinetobacter, Pseudomonas, and when you can rule out two options, you should go for the answer, right? Even if it is wrong, you should go for it. So Stenotrophomonas is the answer here, and you understand why. Look at the next MCQ. An anti-diabetic drug causing a decrease in HbA1c by causing an increase in GIP and GLP-1 levels and decrease in glucagon. It is an oral drug causing reduction in both pre and post-prandial glucose. The drug is, guys, This is an easy one. Please let me know the answer. Please let me know the answer in the comment box. This is not a difficult one. This is an easy one, right? So answer here is allogliptin, because the DPP4 inhibitors or gliptins, when you block DPP4, it increases the glucagon-like peptide 1 and gastric inhibitory peptide. That increases insulin level, and that secondarily decreases glucagon. Now, this is what they have asked here. This is what they have asked here, and the answer is a gliptin, right? Which of the following acts via JAK-STAT pathway? Now, see, here, again, if you don't know the direct answer, you could have ruled out. You could have ruled out, number one, the calcitonin and vasopressin receptor. These are GPCRs or G protein coupled receptors. Aldosterone receptor, it is a nuclear receptor. All of you know that, which is present where? In the cytoplasm, right? Now, leptin. Leptin belongs to the cytokine subfamily, cytokine family. Now, if you knew this, you could have solved this directly. Your answer is leptin, because I've told you an example of JAK receptor. One is prolactin, one is growth hormone, and one is cytokine receptors. Now, this is what I teach you. And if you knew that leptin receptors, so there are two ways of solving this, right? If you knew it belongs to cytokine family, cytokine receptors are JAK receptors, answer is leptin. Or you could have ruled out by ruling out calcitonin and vasopressin. So at least calcitonin, vasopressin, you could have ruled out. Aldosterone, nuclear receptors, we know this. Remaining one is leptin. So this is how we solve MCQs. See, I do not need to know the answer always, right? So by hunch, I can solve the MCQs as well. Now, moving on to the next question, guys, you can see here, which of the following is not responsible for teratogenicity due to thalidomide? Now, see here, look at thalidomide. Cause of teratogenicity. What are the molecular targets? It blocks cereblon and tubulin. Now, block of this cereblon and tubulin, it blocks vasculogenesis, blood vessel synthesis, plus in the embryo. I'm talking about the embryo, right? Plus, it produces free radicals and ROS, reactive oxygen species. Together, this can cause a defect in organ and tissue development, and that causes teratogenicity. So, this is the pathway of teratogenicity of thalidomide. This MCQ has been made from this pathway, and you can see here, if I remove all of these as seen, your answer is inhibition of interleukin 2, interleukin 4, interleukin 5. So inhibition of these interleukins, it produces anti-inflammatory effect. Now remember, thalidomide is anti-inflammatory, it is immunomodulatory, it is anti-angiogenic drug, it is anti-neoplastic drug. Inhibition of interleukin 2, 4, 5, they have to do with immunomodulatory or anti-inflammatory. They have nothing to do with organogenesis or teratogenicity. So other three options are seen. So answer is option D here, right? Next question, guys, is an easy one. A child went to temple, presented with raised BP, lacrimation, sweating, prolonged priapism. What is used in treatment? Now see, prolonged priapism gives away the answer here. It's a case of scorpion bite. Scorpion bite. So many of you would have thought that it's a case of organophosphate poisoning, but organophosphate poisoning can have lacrimation, sweating, but priapism would not be seen. So here, say scorpion bite. Scorpion bite can cause prolonged priapism. What is used in treatment? What is used in treatment? Again, what is the drug of choice for scorpion bite? It is prazosin. So in prazosin, blood pressure can be elevated, and that elevated blood pressure can give these symptoms of sweating, lacrimation as well, right? Sympathetic access plus prolonged priapism. So prazosin is the drug of choice. So whenever they ask you about scorpion bite, whatever be it, priapism, hypertension, pulmonary edema, your answer is always prazosin. Which is rare but a severe side effect of clozapine that requires regular monitoring? Guys, again, let me know the answer in the comment box. It's an easy one. Come on, comment. Let me know. What is it? All of you must have answered. It is A, granulocytosis, right? So, see here, I monitor the CBC, complete blood count, and to be specific, neutrophils, I need to monitor. But remember, I don't monitor plasma concentration. You don't monitor plasma concentration of clozapine. The reason being, the plasma concentration of clozapine does not correlate well with agranulocytosis, which means I do not do TDM. therapeutic drug monitoring for clozapine. So this is one MCQ that has been asked earlier. Second MCQ, they have asked you, because clozapine causes agranulocytosis, it is contraindicated with which drug? Your answer is carbamazepine, because carbamazepine also causes agranulocytosis. So there's a couple of MCQs which have been asked, right, with respect to this. A patient underwent a hysterectomy and was given morphine in the post-operative period and in the ward for pain. She now presents with respiratory depression, pinpoint pupils. What is the drug used in treatment of this condition? I cannot even count how many times they've asked this question. Again, it's an easy one, right? The difficult ones, I'm not asking you to comment, but at least comment the answer for this one, guys. All of you know the answer. The answer is option A, that is naloxone, is case of opioid toxicity. And what is the drug of choice for opioid toxicity? Is naloxone. There is nothing more I can say. Now, guys, we've come down to the last question for today's session. And see, cyclosporine-induced cholestasis is due to which receptor? Now, again, this is an MCQ again out of this world. And there are so many receptors like P-glycoproteins, the BRCA, OATP1B1, MRP, MDR. It is physically not possible to remember all of them. But nevertheless, they have asked here, I'll tell you the answer. The answer is MDR1 receptor, and it's a type of P-glycoprotein. And see, MDR1 P-glycoprotein, these receptors, there are multiple receptors which are responsible for excretion of bile acid, and these are also responsible for excretion of drugs. So there is a competitive inhibition, and because of which bile excretion is blocked, and that causes cholestasis. So here, this protein, it is responsible for excretion of, you can see, xenobiotics, cytotoxin to blood, include cholestatic drugs like cyclosporine. So answer is MDR1, and the other options you can see erythromycin, verapamil. Now, do I need to mug up all these drugs? It's not required, guys. That is not how we prepare for a competitive exam. But yes, if this cyclosporine drug is repeated once again, you should be able to answer. Similarly, BRCP, right? It is associated with cholestasis with anthracyclines, rosuvastatin, etc. Similarly, the anti-CP, sodium tau chloride cotransporter, right? Taurocolt cotransporter, estrone 3-sulfate, rosuvastatin. OATP transporters, they transport organic anions mostly, right? Organic cationic transporter, OCT1 for cimetidine, metformin, acyclovir, zidovudine. OAT2, organic anionic transporter 2 for salicylates, prostaglandin E2. And at last, the MRP2 or ABCC2. These are responsible for excretion of drugs like ceftriaxone, diclofenac, synthetic estrogens, pravastatin, methotrexate. Now, you have seen the list. Now, is it humanly possible to mug up all these lists? It is not possible, guys. Right? So don't waste your time in mugging up these weird MCQs, because let me tell you something. Time to time, the INI-CET exams, specifically AIIMS and JIPMA, they are known for asking weird subjects. At least they'll hold some subjects. Like this time, it was PSM, Pharma, and Optha. So it happens. Sometimes they ask weird questions. That does not mean I'll spend half of my time behind those weird questions. All right, what can I do? I can remember what point has been asked, so that if it is repeated again, I should be able to answer it. If weird points are asked, nobody can answer that. And that is why they are not the rank deciding questions. So guys, this is what I had to offer in today's discussion, and I wish all of you all the best. No matter what your result is, never lose heart, right? You know that you are capable of more than what you think, and you will clear the next INI-CET or the NEET PG or next whatever comes. Never stop believing in yourself and keep moving forward, right? If you have still any doubts with respect to whatever we have discussed today, you can let me know in the comment box. I'll try to answer there. Or you can DM me on Instagram, my Instagram handle, DocPharmaniac, right? You can anytime you can message me for any doubts you have, and I will reply you as soon as possible. I reply within 1 day. So guys, thanks a lot for watching. Take care. Bye-bye. This was Dr. Ranjan, your pharmacology faculty at Mero.